Next, we're going to look more at the ovaries. The blood supply to the ovaries includes the ovarian arteries and a branch of the uterine arteries called the ovarian branch. The ovaries are also surrounded by a fibrous tunica albuginea, and they have an outer layer of germinal epithelium. They have two poorly defined regions, an outer cortex and inner medulla. Keep in mind, it is very poorly defined. Embedded in the cortex generally are ovarian follicles. Follicle cells are just one cell layer thick, so anything thicker than one cell layer is called granulosa cells. So those are more than one layer thick. And inside the follicle cells and the granulosa cells would be an immature egg or a primary oocyte. So that's what would consist or make up an ovarian follicle. There's different stages of development for these follicles. One of the earliest stages is a primordial follicle with a single primary oocyte and a single layer of follicular cells. More mature follicles have several layers of granulosa cells and may even have a fluid-filled antrum. An antral, tertiary, or vesicular follicle is the name for a fully mature follicle. This is one of the ones with that fluid-filled antrum. And we would see that this type of follicle bulges from the ovary surface right before ovulation. Ovulation is the ejection of an oocyte from the ripening follicle. The cells, whether they're granulosa cells or not, that are left behind after ovulation form the corpus luteum. The corpus luteum is actually a hormone-producing structure, but it develops from ruptured follicular cells after ovulation. Here is a cross-section of an ovary. We can see that the cortex is on the outside, the medulla is on the inside, but we have follicles both on the outside and on the inside. So again, those areas are going to be really poorly defined. We're going to continue looking at the female duct system. What's interesting about the female duct system as opposed to the male duct system is that the female duct system has no contact with the female gonads, no contact with the ovaries at all. Instead, the oocyte, when cast from the ovary, is cast into the peritoneal cavity, and some are actually lost there. But most of them are going to make it into the uterine or fallopian tubes, also known as oviducts. And then from the uterine or fallopian tubes, the female duct system proceeds to the uterus and then to the vagina. We'll look closely at the uterine tubes first, and again, they're what receive the ovulated oocyte, and the uterine tubes or fallopian tubes are the usual site of fertilization. There is an isthmus, a constricted region where the uterine tubes join the uterus, so that's going to be located closer to the uterus and further from the ovary. The ampulla is going to be close to the infundibulum, and the infundibulum is the nearest structure of the uterine tubes to the ovary, other than the ciliated fimbriae. These fimbriae are kind of finger-like projections that move back and forth to create currents and move the oocyte into the uterine tubes. Adjacent to the fimbriae again is the infundibulum, adjacent to the infundibulum is the ampulla, and then closest to the uterus is the isthmus of the uterine tubes. The oocyte is carried along the uterine tubes by contraction called peristalsis that you've also seen or heard about when talking about the alimentary canal, but also it's going to be preceded by or helped via ciliary action of cells in the uterine tubes. There's also non-ciliated cells that nourish the oocyte and sperm, and they're covered externally by the peritoneum, the uterine tubes are. And then you have the mesolpinx of the broad ligament. It's just a mesentery that supports uterine tubes. So here is the mesolpinx, and we can see that it's included in the broad ligament that supports not only the uterine tubes, but the ovary and parts of the uterus as well. A homeostatic imbalance we want to mention is an ectopic pregnancy, which is when the oocyte is fertilized in the peritoneal cavity or the very distal end of the uterine tube. And when that oocyte is fertilized there and begins developing there, it's called an ectopic pregnancy. But normally these types of pregnancies abort naturally and have substantial bleeding as a result. Pelvic inflammatory disease, or PID, is the spread of infection from the reproductive tract to the peritoneal cavity, which is possible through the uterine tubes. This can cause scar tissue, which leads to infertility. We're going to move now from the uterine tubes and look at the uterus, which is a hollow, thick-walled muscular organ. Its function is to receive, retain, nourish the fertilized ovum, and it can be anteverted or retroverted but it has a couple of different parts. The body is the main portion, and then there's a superior region above where the isthmus of the uterine tubes attaches to the uterus, and it's domed. That's called the fundus. And then the inferior region that is narrowed towards the cervix is the isthmus of the uterus. The cervix is the narrow neck or outlet of the uterus, so it's projecting slightly into the vagina. There's a cervical canal within the cervix, and it has an internal and external opening. The vagina is going to be close to the external os of the cervical canal, and the uterus, or the uterine body, is going to be close to the internal os of the cervical canal. And there's cervical glands that secrete mucus that are able to block sperm entry through the cervical canal, except during mid-ovarian cycle. We also want to talk about cervical cancer. Cervical cancer is most common between the ages of 30 to 50 in women, and risks for the development of cervical cancer include having frequent cervical inflammation, STIs, or multiple pregnancies. A pap smear is recommended for detection every 2 years if you're between the ages of 21 and 30 in female, and then every year if you're over the age of 30. For females, they can discontinue at 65 years of age if they've had negative pap smears for 10 years prior. About 450,000 women worldwide are diagnosed with cervical cancer, and cervical cancer usually ends up killing about half that number. If your pap smear is inconclusive, it's possible that you have tested positive for human papillomavirus, or HPV, which is the cause of most cervical cancers. Now, having HPV does not mean that you will get cervical cancer, but it does definitely increase your risk. So a treatment for that, kind of a prevention step, is a 3-dose vaccine that protects against HPV called Gardasil, which is recommended for 11 and 12-year-old girls. Let's also look at the 3 layers of the uterus. The uterine wall is made up of the perimetrium, myometrium, and endometrium. The endometrium is the inner mucosal lining. The myometrium is the smooth muscle layer. The perimetrium is the outer layer. It is a serous layer made up of visceral peritoneum. The endometrium contains a functional and basal layer. The stratum functionalis changes in response to ovarian hormones, whereas the stratum basalis is unresponsive to ovarian hormones. It is the stratum functionalis that is shed during menstruation, and the stratum basalis that forms the new functionalis after menstruation. Branching off of uterine arteries are arcuate arteries. The arcuate arteries are in the myometrium and branch into radial arteries, and the radial arteries are in the endometrium and they branch into straight arteries. Make sure you know that straight arteries are of the stratum basalis, and branching off of the straight arteries are spiral arteries. They are of the stratum functionalis, and it's these spiral arteries that can degenerate and regenerate via spasms, which cause the shedding of the functionalis layer during menstruation. So here we can see a spiral or coiled artery, and it would be these arteries that spasm and are shed in the stratum functionalis. But we can see our uterine artery down here. Branching off of that is the arcuate artery. Then you have the radial artery up in the myometrium, and then adjacent straight arteries going into the endometrium, and then of course the spiral arteries, which are shed. We're going to move away from the uterus and now talk about the vagina. The vagina is a thin-walled tube about 8 to 10 centimeters in length. It's the birth canal, it's the organ of copulation for females, and it extends between the bladder and rectum from the cervix to the exterior. So it's located between the bladder and rectum in females. The urethra of females parallels the course of the vagina anteriorly, so it's in front and it's embedded in the anterior wall, the urethra, not the vagina. Layers of the vaginal wall include the fibroelastic adventitia, so that's outermost, the middle smooth muscle muscularis, and an inner stratified squamous mucosa. These mucosa also have folds called rugae. We can find dendritic cells in the mucosa. We also can find an incomplete partition near the vaginal orifice. It's an incomplete partition made up of mucosa, and it's called the hymen. It can rupture with intercourse or just by kind of daily activities such as riding a bike. Vaginal fornix is a structure that we want to talk about. It's the upper end of the vagina surrounding the fornix. So it's the part of the vagina near the cervical canal. It envelops what of the cervix does go into the vagina. We also want to just briefly look at the female perineum. The female perineum is outlined laterally by the ischial tuberosities, anteriorly by the pubic symphysis, and posteriorly by the coccyx. Structures we want to know that are in the female perineum are the mons pubis, a fatty area overlying the pubic symphysis, the labia majora, which are hair-covered fatty skin folds. They're actually a counterpart to the male scrotum, and the labia minora sit within the labia majora, and they join at the posterior end of the vestibule to form the fourchette. The vestibule is everything inside the labia minora. It's the recess within the labia minora. So let's go back and look at that. We have the mons pubis, labia majora, labia minora, and then everything within the labia minora is the vestibule. You can see within the vestibule the external urethral orifice, which is anterior to the vaginal orifice. Also, with the external genitalia, we want to acknowledge the greater vestibular glands, which we can't see in that perineum photo, but we could see in an image that's coming up. They are actually glands that flank the vaginal opening, and they're homologous to the male bulbourethral glands. So they're able to release a mucus into the vestibule for lubrication. We're also going to look closer at the anatomy of the clitoris, which is anterior to the vestibule. The glands of the clitoris and the prepuce of the clitoris are structures we'll point out. The glands is the exposed portion, the prepuce is the hood of the clitoris, and the clitoris is a counterpart to the male penis. And we just looked at the female perineum, and if you need the outlines again, they're listed here, so bordered laterally by the ischial tuberosities, and then anteriorly by the pubic arch or pubic symphysis, and posteriorly by the coccyx. So the perineum is just a diamond-shaped region that we'll find within these outliers, and generally has the external genitalia located therein. Here are the greater vestibular glands. So we point those out. And the fourchette, which is the posterior end of the vestibule. And then we have bulbs of the vestibule. So just structures to point out, these are underlying parts of the external genitalia or vulva of the female. Then we can see here the prepuce of the clitoris, right here. And then missing is the hood of the clitoris, which is up there. We'll also talk briefly about the mammary glands. They may seem not to fit in this chapter. They actually would fit much better in the integumentary chapter. But for the purposes of our textbook, we're going to discuss them here. So mammary glands are modified sweat glands consisting of 15 to 25 lobes. They're for milk production. The areola is pigmented skin surrounding the nipple. There are suspensory ligaments that attach the breast to underlying muscle. And there are actually lobules called alveoli, but they're glandular alveoli under the breast tissue. So there's a lot of fat in glandular alveoli. The glandular alveoli produce milk. So the milk will travel from the glandular alveoli to lactiferous ducts, which are a little bit more narrow than lactiferous sinuses, which expand. And then from the lactiferous sinuses, milk will then travel to the outside of the body at the nipple. And breast size is not due to the amount of glandular alveoli. Instead, it's due to the amount of fat deposits. So here we can see an image of the mammary glands, and we can see that there is fat and some round structures. Those are the glandular alveoli. On the outside, we can see the nipple and the surrounding tissue, the areola, and we can also see that the glandular alveoli are arranged in lobes. Attached to each lobe of glandular alveoli is a lactiferous duct. From the glandular alveoli, milk would enter into a lactiferous duct, then a lactiferous sinus, and then eventually make it out of the body via the nipple, and that would be the openings for the lactiferous duct, where it exits the body. And the reason we're talking about mammary glands here is we want to discuss breast cancer as well. Breast cancer is one of the most invasive types of cancer because it's also very metastatic. It's the second most common cause of cancer death in U.S. women. It's a very common malignancy, and about 13% will develop the condition. It usually arises from epithelial cells of the smallest ducts in the mammary glands, and again, it's highly metastatic, so usually breast cancer eventually metastasizes or moves to other organs. So risk factors for the development of breast cancer include early onset of menstruation, late menopause, having no pregnancies, or if a woman has her first pregnancy later in life, no or short periods of breastfeeding, and especially a family history of breast cancer. We do know it has a genetic component. And about 70% of women with breast cancer have no known risk factors. But again, let's look at that genetic component. So 10% of breast cancers are due to hereditary defects, and this includes mutations in a couple of genes. The BRCA1 and BRCA2 gene are two identified genes that we know that if there are mutations in these genes, there's an increased risk for the development of breast cancer. About a 50 to 80% risk exists for those who do have mutations in BRCA1 and 2. And this also includes a greater risk for ovarian cancer as well. So diagnosis of breast cancer is usually done via mammography, but it's best if there's early detection of breast cancer. This can be either via self-examination and then mammography, or getting regular mammographs. A mammography is an X-ray examination, and depending on which society you prescribe to, like the American Cancer Society, which recommends screening every year for women that are 40 years of age and older, or the U.S. Prevention Services Task Force on Breast Cancer, which recommends mammographies for individuals who are 50 years of age and older. You just want to make sure that you're getting regular mammographies at your appropriate time. If you're at a greater risk for developing breast cancer, it may be paramount for you to get a mammograph earlier. And treatment depends on a couple of different characteristics, whether or not the cancer has metastasized, whether or not the cancer is responsive to estrogen drugs. So treatments can include surgery, but also radiation and chemotherapy. Sometimes surgery followed by radiation and chemotherapy to destroy any extra or stray cells that may have been missed, especially since breast cancer is metastatic. Drugs for estrogen-responsive cancers include trastuzumab, tamoxifen, and letrozole. And so depending on which cancer you have and whether or not it's estrogen responsive, your type of breast cancer can be treated a couple of different ways. However, most of the treatments do involve surgery, and there is a radical mastectomy, lumpectomy, or simple mastectomy that can be chosen from. A radical mastectomy removes not only the breast, but all underlying muscles, the fascia-associated lymph nodes, such as those that are in your armpits, so the auxiliary lymph nodes, whereas a lumpectomy would just excise or cut out the cancerous lump, and a simple mastectomy would remove only the breast tissue and sometimes some auxiliary lymph nodes if they've become infected. And it is optional to have breast reconstruction. Here is the mammogram procedure. So you can see the machine here is an X-ray exam. We can see on the right a film of a normal breast and the film of a breast with a tumor. And we're going to stop there and next time talk about the physiology of the female reproductive system.